Hi, I'm Brian Mandel, the editor-in-chief of the Cleveland Clinic Journal of Medicine, CCJM. Welcome to Beyond the Pages, CCJM podcast, where we will take you in depth into the content of selected articles from the Cleveland Clinic Journal of Medicine and explore a few interesting tangents along the way. Through moderated interviews with our authors and other experts in the field, we hope the clinicians will gain a more nuanced perspective of clinical concepts that are changing the practice of medicine and be able to apply this perspective to the care of our patients.
Welcome back to part 2 of our conversation. Please be sure to listen to part 1 of this episode. Now let's go back, beyond the pages. So do you think, Dr. Calhoun, that actually breast imaging technology contributed to the changes in the way breast lesions are approached?
One example that I can think of relatively recently is, the introduction of three-dimensional tomosynthesis for screening. I think the data are fairly clear that the false positive recall rate from screening is lower, cancer detection rate is higher, and also we're all seeing more cases of architectural distortion, and a higher proportion of those cases are turning out to be radial scars than we used to see. And that's one example where the imaging modality can make a difference in terms of what we see.
And I was just going to say, Dr. Crow continued with his interest in this question. Back in 2003, he wrote a paper looking at does core needle biopsy really accurately reflect breast pathology, and found that in looking at patients who had these findings, the majority, 83% of patients, the core needle biopsy findings demonstrated exact histologic agreement with the excisional findings. But in 12% of patients, the core needle biopsy was upgraded to malignant pathology at the time of surgery. I just wanted to add that in, that over time there have been varying upgrade rates with these lesions, and the upgrade rates are not particularly consistent. They range widely. And I wonder, Ben, if you can kind of talk a little bit about that. But why did there used to be an upgrade rate of, say, 25% with many of our atypical lesions, and now it's, say, 3% or 2%? How is that explained?
I think a couple of ways. A couple of contributors would be sample size in some of the earlier studies was relatively small. I think that a lot of these studies, including studies I've published, are single institution retrospective studies. That has an impact. The other thing we have to always think about when patients are selected for surgery versus not is what the selection criteria were. They're often not clearly outlined. So there's selection bias. I think people who take care of breast patients have a pretty good idea who really needs surgery, and so patients who are most likely to be upgraded may be selected for surgery. When you do retrospective studies and then without clearly defined criteria, that makes it hard to follow that up.
Yeah.
The other thing that's missing in some of the studies is follow-up for the patients who weren't excised. So we also then don't know what happened to those patients. But in terms of the lower upgrade rate, I think it's a clearer definition of upgrade. So we mentioned whether you include high-risk lesions in your definition of upgrade, but one thing that probably shouldn't be included in cases that are defined as an upgrade are patients with a palpable suspicious mass. That should be excluded. We should be talking about non-palpable lesions, probably detected at screening, and then an image-guided core needle biopsy, and then whether those are upgraded or not. We would also exclude patients with BI-RADS5 imaging. Those have a very high likelihood of being malignant, and even if the subsequent core needle biopsy is benign, they can often go straight to surgery. So I think case definition had something to do with that too.
And certainly, atypical duct hyperplasia is typically still excised, and the more aggressive forms of lobular carcinoma in situ, the florid LCIS or pleomorphic LCIS, those are excised and not observed. Are there other lesions other than ADH and the more aggressive LCIS forms that really are still typically excised most of the time?
I think those are the main ones, and you make a good point. So we talk about atypical hyperplasias, and that's atypical ductal hyperplasia and atypical lobular hyperplasia. And we often then include classic type lobular carcinoma in situ with ALH under an umbrella term of lobular neoplasia. And then other lesions we think about are radial scars and papillomas. And papillomas without atypia is what we would be focusing on in terms of talking about an upgrade. Those with atypia.
Right. Papillomas with atypia are typically excised as well. And you had asked about the different types of breast biopsies, and the challenges associated with that. Patients will have stereotactic breast biopsies for calcifications or very, very small lesions. They'll have MRI guided biopsies for lesions that are not seen by ultrasound but are suspicious on the MRI. And ultrasound guided biopsies are probably the most common and the easiest to perform when a lesion is seen by ultrasound and can be targeted. But there are core needle biopsies and vacuum assisted core needle biopsies where the vacuum assisted technology, 8 to 10 samples will be collected without withdrawing the needle as this mechanism rotates position and collects additional samples. So the sampling is not the same, whether it's a stereo, an ultrasound guided, an MRI guided, or vacuum assisted. Does that affect your ability to interpret these findings and make distinctions between these different lesions pathologically?
It certainly affects the volume of tissue that we receive. A lot of stereotactic core biopsies are 12 gauge or maybe larger, 9 gauge. A lot of the MRI guided core biopsies are 9 gauge. Some ultrasound guided core biopsies may be 14 gauge, smaller diameter instrument. And that does affect to some degree our ability to evaluate these lesions. It also just really impacts the volume of tissue that we receive. And a lot of the studies of upgrade rates for core needle biopsies have shown that the upgrade rate goes down as the adequacy of sampling increases. The number of cores that are obtained under vacuum assistance, as you mentioned, and the gauge of the needle. And then going back to radiologic pathologic concordance, the degree to which the targeted lesion was removed by the core biopsy procedure. All of the things impact the upgrade rate.
So it looks like we still don't have a consensus for managing the benign high-risk breast lesions. So what do you think, what kind of well-defined evidence-based criteria are needed for actually selecting the patients for non-surgical management of the benign high-risk lesions?
So far, the primary care provider now has a list to go back to their institution. Do you have dedicated breast pathologists working with dedicated breast radiologists to make this distinction of radiologic pathologic concordance? Are there standardized sizes for the needles used for sampling, number of passes, amount of tissue that's collected, different imaging findings that prompt the biopsies? I mean, what the primary care provider is looking for are guidelines, statements by which to determine a course of action to improve predictability and quality. And there are so many different nuances that lack consensus in this area.
So actually, before going to this, I was asking more broadly, because each hospital might be different, may have different surgeons, different pathologists, but as a whole medical community or health system, we need criteria, recommendations, or guidelines, right, that we can follow. So what would be the next steps to reach to those levels? Because otherwise it's just preference of the surgeons, of the pathologist, and we didn't even discuss about the preference of the patient, because that might play a role in deciding between surgical intervention and observation.
And are the patients really being offered that choice? And should they be offered that choice in this situation? I think that the best place to start, in my opinion, is looking at average risk patients who have calcifications on their screening mammogram and they're asymptomatic. What do you think, Ben? What do we need to get this well-defined evidence-based criteria going forward to have clear guidelines?
I agree. I think we need really we need to determine what the criteria are for selecting patients who may be offered active surveillance. And I would mention that, that it would be active surveillance, and that we're not saying that a patient would not ever have surgery, just would not have an immediate surgical excision after that core needle biopsy diagnosis. I think we have a template for this, a reasonable template for how to proceed. There used to be widely varying definitions of a positive margin after breast conserving surgery for breast cancer. The acceptable margin width that meant you did not need to go back and re-excise varied across the country. And the frequency of margin re-excision surgery varied widely across the country. And what eventually happened was the National Academic Surgical and Radiation Oncology Societies got together. They commissioned a meta-analysis first. Then they met and developed a consensus statement on what was the appropriate definition of a positive margin after breast conserving surgery. This was subsequently endorsed by ASCO. And now I think that's been widely embraced by practitioners across the country and in a variety of different settings. So I think we have to, and that's, by the way, that's for patients who are undergoing breast conserving surgery specifically, who will have whole breast radiation therapy after surgery, and who will be offered and take, ideally, endocrine therapy if they have hormone receptor positive breast cancer. So it's for that subset of patients with contemporary multimodality therapy. I think we need to come up with a similar patient population definition, a similar comprehensive review of the literature, and then leadership from our national leaders in breast care to help us develop a consensus.
I agree. And, patients can trust that when large prospective randomized studies are performed, that the data supports observation when it is recommended in that setting. I'm not sure that we have that data as of yet, and patients are very hesitant to de-escalate cancer therapy. Patients that are newly diagnosed, for example, will accept aggressive treatments with significant side effects for even a 1% benefit in survival. With older patients, we need to talk both about overall survival, but also disease-free survival. If older patients aren't treated as aggressively, and commonly a 70-year-old will live an additional 18.7 years, they need to understand disease-free survival, the likelihood that they may have another problem in the future. So will these women accept even a small chance of upgrade in avoiding excision? It is an interesting question.
In terms of patient preference too, we may have some guidance from one of the low-risk DCIS trials of active surveillance. The LORD trial in Europe opened in 2017, and most of the patients who were consented then refused to be randomized to either surgery or active surveillance. They wanted to choose. So 3 years later, in 2020, the trial was converted to a patient preference trial, and accrual has gone up 40%. So that we may have to give some very serious thought to patient preference in this area.
And, active surveillance and, the MRI screening coming in twice a year and alternating your mammogram with a screening breast MRI that has a 24% chance that a patient will be called back on their first MRI, an 8 to 9% chance that they'll have a false positive biopsy. Primary care providers really need to understand the anxiety that can be associated with active surveillance. Of course, if they have atypical hyperplasia or LCIS on the core, they still will be offered that type of a program and follow-up. But if they have a papilloma or a radial scar or flat epithelial atypia, another benign lesion, and nothing further is found at the time of surgery, they may not have to undergo that active surveillance.
So if I understand correctly, in centers like ours or Dr. Calhoun, we might be able to select some patients for observation of some of the benign high-risk breast lesions. However, I think from our discussion, I don't think we are ready for the widespread implementation of observation across the country, across all the vulnerable populations, and without taking in consideration patients' preference. So any final words?
Well, one thing that you mentioned in terms of standardization, we must agree on the definition and processes for determining radiologic pathologic concordance with systems in place to assure quality. We have to agree on the age and, importantly, the risk level of patients in whom observation is recommended. We have to agree on the imaging findings, the sampling issues, the histologic findings, and patient follow-up issues. And informed shared decision-making with the patient must be part of the process, as well as large prospective studies and long-term oncologic safety data. And you bring up another important point about follow-up in vulnerable populations. I mean, we know that probably one of the most embarrassing areas in medicine is the disparities that are observed in breast cancer care, and the follow-up of high-risk patients is no different. We see that in women with low socioeconomic status, they have less access to high-quality mammography, poorer follow-up, less participation in high-risk programs. Insurance coverage is a huge issue for MRI screening and even preventive medication. So when these factors are taken into account, you really need to think about whether you don't want to excise benign high-risk lesions.
So thank you so much, Dr. Peterson and Dr. Calhoun, for your insights and helping us go beyond the pages of the Cleveland Clinic Journal of Medicine. Thank you.
Thank you, Ben, for the work that you've done in this field, and thank you for having us today.
Thank you.
Thank you for your insights in helping us to go beyond the pages of the Cleveland Clinic Journal of Medicine. To read CCJM articles, visit ccjm.org. To participate in other accredited educational activities, visit ccfcme.org. You can subscribe to the podcast on Google Play, Spotify, or however you prefer to access your podcasts.